Welcome, Professor Serruys. I'm here in your office. We didn't have the chance to talk at PCR because it was so busy. So this is really post-PCR and not post-PCI, but post-PCR. and very happy to be here. And I think at PCR we had, among others, a great TNT session where you also gave a presentation. And one of the points I think that you also defended is that we have used for so many years the late lumen loss as a special parameter to follow up, say, the development of the stent placement in the vessel. And now with all the physiology, I think there is a tendency, and you promote, let's also include physiology in those analyses. So you promoted anatomy plus physiology and then the QFR for a number of studies that you have done.
So the first thing we can say is that we know each other and we have been working together for 40 years.
Yes,
This year is 40 years.
Okay.
No, the late loss is indeed a creation of derived from the quantitative angiography. It was very, very useful for almost 3 decades. It has been embraced by the regulatory body as a kind of assessment of the performance of device. It is in the executive summary of the Task Force on Angioplasty and Device by DSC, but obviously it's not the final word. It's not because you have 20, 40, 60, 100 micron of tissue that you feel better or less well. So I think that I am strongly recommending the regulatory bodies to change their vision and to use something which is physiological, because after all, that's what helps the symptom of the patient by eliminating the ischemia. So I'm very much in favor in the call-up, in future assessment of device, and there will be drug coating balloon, there will be many other things, lithotripsy, and so to progressively go to the physiological assessment, QFR, rather than late loss. The big advantage of the QFR is that you don't need to instrument the coronary artery, so you can always retrieve the information retrospectively, and we have done that in many trials, and I think that in general the device company are happy to see that a careful clinical event adjudication is almost as good, or QFR is almost as good as this complex adjudication. So I think it's an objective piece of information which will be there for post-device assessment.
So that is very clear from your point of view on the core lab, the CRO uses of QFR. And now, with all your experience, how about the clinical practice, daily clinical practice? Where do you see the opportunities?
I think that I used to say that it could become a tsunami in intervention, in the sense that, of course, at each step of the procedure, it can be used. Of course, it can be used to justify the procedure. The pressure-derived assessment was almost a moral must. You have to do it. But it is costly, it takes time, it's in comfort if you use adenosine for the patient. While this is available to Mr. Everybody, it's not a distraction for your usual clinical practice. So pre-procedure, you have to justify what you are doing. I'm doing a PCI because that lesion needs to be treated, and vice versa. The other one should not be touched because device is always inducing restenosis. And we have seen that there is today more restenosis problem than deferred problem. Mm-hmm. Deferred is very, very safe. Post-procedure, what is emerging is that if you are above 91, 92, you will have a good outcome in the long term. And then finally, when the patient comes back and nevertheless has a restenosis or at the progression of the disease in another area, so what we call a non-target vessel, there also it would be a good way to say that restenosis must be treated. It's a must. This non-target vessel is a real progression with physiological implication, and then you have to treat it. So at the tree level, it will be there, and of course, that's clinical practice, but also for any trial, it will be extremely relevant.
Yeah. And as we just mentioned in the beginning also, I found the TNT session at PCR very educational from all points of view. The video was very good, the discussions were good, your presentations were excellent, and what I really liked very much your statement at the end of the meeting where you say, what did you say about the annual license? You said, the more you use it, the cheaper it becomes. And I think that is a great slogan.
You know, it's in every meeting we say the more is less, and the less is more. So this is, it's obvious, is that if you have to open the package of a pressure wire for any situation when you doubt about should I treat that vessel, every time it will be the cost of a pressure wire. And it's cumulative, of course. There is no discount on the use on the long term. But vice versa, once you have the license, the more you use, the most cost effective is the price of the license. So that's very important. What I would like to add is that I'm sure that you must enjoy that, is that when we create together the QCA, it's amazing to see the history of QCA, because it was there, it was even three-dimensional in 1982, and then suddenly you see the velocity Y, the pressure Y, quantitative angiography was almost denigrated and ridicule, and thanks to the 3D, thanks to the input of company with multi-slide CT scan, color-coded, we came to that. And today is amazing to see that the big expert in physiology, the people who have strong proponent for 20 years on IFR, FFR, and so see the value of the QFR. I think that's a nice twist in the history of physiology and anatomy.
I think we can call that our second life.
Second wind. Second life and second wind. Maybe we'll have a third one.
Okay. Well, I mean, it was a great pleasure to have this interview with you at your office here, and thank you so much. And
you're welcome.
We will do a lot more in our second life.
Yeah, we'll do. Yeah.
Thank you so much.